that
Yeah.
your learning zone, what's called the learning zone or the zone of proximal development, is where you're uncomfortable, right? Getting beyond what you know and what you know you can do into that uncomfortable zone, that's kind of where the magic happens, where you're really learning, which also means you're making mistakes and errors, right? But as long as that's in a system that, again, can catch those errors before they become actually patient related issues, that, and as long as you're learning from those mistakes, you say, I made a mistake, I accept it, this is what I did wrong, this is what I'm going to learn from it, do next time. That you accept those errors and you get into that uncomfortable space where you're really learning. That, I think, requires you to kind of push yourself a little bit out of that comfort zone that we all have.
Welcome back to the Deep End Podcast, where we go deep into the art of science and leadership shaping plastic surgery. Today, we're joined by Dr. Nguyen, the Health Sciences Endowed Chair in Plastic Surgery Education, Vice Chair of Education, Program Director for both the Integrated and Independent Residency Programs, and Co-Chair of the GME Well Task Force at the University of Pittsburgh School of Medicine and UPMC. Dr. Nguyen isn't just training residents, he's helping redefine what surgical education looks like in 2026 and beyond. From curriculum innovation to resident wellness to leadership development to job satisfaction and negotiation, his fingerprints are all over the next generation of plastic surgeons. Today, we'll talk about building elite training programs, balancing excellence with humanity, and what the future of plastic surgery education should look like. Dr. Nguyen, welcome to the Deep End.
Thank you so much for joining.
Absolutely. This is a real pleasure. Again, thank you so much for doing this and for inviting me. These are incredibly fun, enjoyable, informational, educational, right? It really hits all the high notes in regards to, and you put on your computer, you can watch it at 1.5 to 1.25 speed, so you can like knock it out and knock out a whole bunch of them. These have been so incredibly enjoyable to watch, and I can tell you that we just had our interviews, and so many applicants reference this, ask questions from this. So like you said, it's being seen like
Cool.
everywhere, and
Well, thank you so
I think it
much.
hits this really sweet spot. So keep on doing it. Production value is great. The questions are great. You guys are great.
Yeah, so we're super excited to have you on the Deep End Podcast for innumerable reasons. And you're one of the people that I think of often when I think about education and academia specific to plastic surgery. And me having known you for such a long time, you're exactly who I think of when I think of academia, education, and plastic surgery. Me having known you for a really long time and seeing you at conferences and the kind of mutual Pittsburgh Penn, relationships, and the fact that you
Yeah.
trained at Penn for microsurgery is just an incredible honor and pleasure to have you on tonight. And I'm so excited to dive in for a number of reasons. When this gets released, we'll be kind of in the midst of interview season. And so it'll be sort of interesting for people to listen to it. But
Oh, absolutely.
I remember like having talked to you in the past, and we have similar sort of training backgrounds in the general surgery, plastic surgery. And I know you did that at
Mm-hmm.
Pittsburgh. Then you completed your microsurgery fellowship at Penn, ultimately returned to Pittsburgh. And I remember from my interview at Pittsburgh, the whole line of leaders on the wall. And so I can only
Mm-hmm.
imagine how it felt to you to return to such a place with such an incredible legacy. But looking back, what were the key experiences or mentors that kind of shaped your academic leadership trajectory?
Yeah, there are really so many. And I think anyone who gets to any type of leadership position or any type of, notoriety, just about anyone has so many mentors, models, sponsors that have helped them along the way, right? You eventually have this kind of cabinet or group of people that have really lifted you up. And that goes from anybody like, Joe Cerletti, who I did my fellowship with, or Joe Losu, who's been my primary mentor for years as a resident and now as a faculty member. And then, interestingly, even those people that kind of come out of the woodwork that you kind of know peripherally, and then you find out that they sponsored you, or they put your name in the hat. I remember when Jeff Janis kind of just almost out of the blue said, "Hey, do you want to run with this thing, the plastic surgery boot camp?" And I was like, Yeah, sure. And out of that, you build a relationship and you have these remote mentors that really lift you up. And then there's like the every day-to-day people, people that you're working with on a daily basis, colleagues, even our residents where they're kind of, you know,
Yes.
pushing upwards. And you learn so many things from so many people if you kind of keep your ears open and, your boots on the ground.
Yeah. And what's very unique to sort of your position is that Pittsburgh obviously has one of the largest residencies in the country, such an incredible legacy. It is a department. These are all these sort of unique items that make Pittsburgh such an incredible place. And you are the program director. And so, what kind of got you into that role and that desire to pursue academia? And can I just tell you this? Oftentimes, I have to admit, it goes through my mind, what would private practice be like? And
Yeah.
I love mentorship, I love residents, I love medical students, I love academia, but what kind of pushed you or gave you the energy to do academics for so long and do it so well as a program director?
I think it's really education, right? We start out as wanting to be, really good surgeons, and then we find out there's more to that. Although you can be 100% clinical, and some of my mentors, particularly here at Pitt, were old school 100% clinical. Then you see, but you find out that there's other things out there. There's obviously research, education, administration, society work, you name it. And through all that, you kind of have to, pick your passions because there's only so much time and energy in any particular day. For me, it was, I grew up in the model of the surgeon scientist. I did 2 years in Andy Lee's lab, and I really thought that's the pathway for me. And as a young, attending, I tried to do the triplicate, the quadruple thing, whatever you want to call it. And I found out that, some of that I didn't do so well. And I really had to come to grasp that basic science research really wasn't really my passion. And it hurt to give that up because that was my model for academia. But that was replaced by what am I really passionate about? What do I really intrinsically like to do? And I found that to be education. We all have these kind of, these areas that we're kind of intrinsically drawn to and we kind of are good at it. But I think the biggest thing was really recognizing that, okay, I may have a little bit of a knack for this, but despite, what we're all asked to do, which is be educators and teach and mentor, most of us aren't formally you know, grown up within that sphere. And
Mhm.
so you have to, at some point, if you really want to hone your craft, think about, okay, what's in the literature? What educational courses or curricula do I need? Who do I need to learn from? And just kind of start doing that deeper dive into it. And like anything else, it's just, you start to do that deeper dive and this whole nother world kind of opens up to you. And
Yeah.
so I think the important thing is also not only kind of educating on the fly, which many of us can do, but really learning what a good educator is and really constantly working at that to try to get better and better.
And I think it goes back to something has to give. We're on top of everything you said, we also are
Yeah.
surgeons and clinically extremely busy. It's so funny. I think about it. When I have an admin day, I have enough work to last me the entire day that sometimes, like, if I never operated, I'd be busy the entire day, every day of the week. Somehow I'd
Yeah,
find stuff to fill it.
absolutely.
And so when you're thinking research education, something has to give. And when you're at a place like Pittsburgh, you guys set the example for education. And so it's nice that you have such a passion for it because it would make sense for the program director to have such a love and enjoyment for education. And now, along those same lines, a very kind of difficult topic for me to digest just out of the logistics of it is competency based training. It makes a
Yeah.
ton of sense to me. So when I was a general surgery resident, my general surgery program director, Pam Lips, had told me, she was like, we're coming up with this new idea. So as a third year general surgery resident, if you knew what you wanted to do, you could then pursue a fellowship within your residency program. So if I was a third
Mhm.
year general surgery resident and I wanted to do transplant, it would become embedded within my residency so that I wouldn't have to do that in the future.
Yeah, absolutely.
I want to hear from you, like, what is the status of competency based training? And then also, like, what's important, because I think this is something we all fear. How do you guys deal with a resident leaving early? Or,
Mhm.
I can only imagine the logistical nightmare.
Yes and no in regards to the latter question. In regards to the bigger question of what is the status of competency-based education, right? So where do we start? So Canada, right?
I guess let's start
Decade
at
ago.
for those listeners, what is competency-based education?
Perfect. So let's start with what we have now, which is a time-based model. So way back when, ACGME and the American Board of Medical Specialties, ABPS for us, designated what is the educational model. And that was time-based, 6 years for plastic surgery, 5 years for general surgery, 3 years for pediatrics. But that is time as a surrogate for competency, saying that in general, it takes 6 years to competently train a plastic surgeon. But that's not a direct measure of competency. It's a surrogate model. And so competency-based education that puts competency first is a situation where you're exchanging the current model, which is time-based but competency variable, for what it should be, which is competency-based, which might be time variable because people learn at different rates. They learn differently. They need different things. And if we can deliver more individualized, customized education, right time, then we can potentially do it more efficiently. It's not really about time, or saving time, which is kind of the sexy thing. It's really about achieving competency on an individual basis and individualized education versus kind of putting everybody within the same 6-year box, so to speak. So it should be better. But the status of it is that the ACGM has asked every medical specialty, pediatrics, plastic surgery, to develop what competency means for them, what a competency-based model means for them. It's different for the surgical specialties versus the medical specialties. It's different for a 6-year specialty versus a 3-year specialty. So we have really the opportunity to define what it means for plastic surgery, which is wonderful. The bad thing about that is that it's a decentralized model. So in Canada 10 years ago, subsequently, since they've rolled out competency-based education, they've been able to do it to some extent because it's centralized. Their ACGME, their version of the Royal College is a combination of the ACGME and the American Board of Medical Specialties. So it's very centralized. They're also smaller, so they can roll out a system-wide initiative like this that is, you can share different aspects amongst the different specialties. For us, it's been a very decentralized process. And so we're just starting to get the players in plastic surgery together, the American Board, the Plastic Surgery RC, society leaders, the association, ASPS, ACAPS, et cetera, et cetera. And so we're kind of putting together this, this core group and going to push forward again, what we consider competency-based education 2.0 for plastic surgery. Us, Pitt, Hopkins, Baylor Scott and White, and it was Michigan were version 1.0 of that experiment. And like any experiment, there have been a lot of failures, mistakes, things we learned from that can allow us to really educate the 2.0 version as we push it out to other programs, both big and small.
Yeah. Oh, so all those programs, all those programs that you mentioned, have they all graduated residents early?
No. So we started in 2018 along with Baylor Scott and White. Baylor Scott and White stepped out of the experiment because they went on academic probation. Hopkins started a year after us, and they have a 1-year mandatory research year. So they're actually 2 years behind us. And then Michigan stepped out, for housekeeping issues. So right now, this year, Michigan has their first competency-based resident finishing. And they're doing a little bit of a different model, which might be more applicable, which is a practice in place model. You finish 6 months or a year early, you get attending privileges to operate, be fairly unsupervised, but you're really kind of supervised because you're in your own institution, you know the players, you can ask for help anytime you need it, but to operate, teach, bill, and so that kind of helps with a manpower issue that you kind of mentioned.
Yeah.
But for us, the manpower issue has not been that big of a deal because we've had this elective lab year for a decade. And because of that, our complement is always fluctuating. We're accredited for 5 residents to graduate, and we've had as much as 8, and we've had as little as 3. And so that requires a lot of prospective planning years in advance to make sure that all those senior residents get the same experience, despite if they're doing 3 or 4 rotations in that year or 7 or 8 rotations in that year. So it is a little logistically tricky.
Yeah. Me just hearing you talk about all of this stuff makes me think, how much time do you dedicate to your role as program director?
Well, officially, it's 0.25 FTE.
Yeah.
So
How about
it's
unofficially?
25%. It's whatever you need to do, right? There's ebbs and flows, but, if you like the problems that
If
are
you love
sent
it.
your way,
Yeah.
they're not so big of problems. They're just things to kinda sink your teeth into and kind of, crunch
Yeah.
on.
So it sounds like, the way of the future. And if it's some iteration of this, because we were at Journal Club a day or two ago with the residents, and one of them who's going into private practice interested in aesthetics told me, why am I spending my chief year doing 4 months of hand, 4 months
Mhm.
of craniofacial? I'm never going
Yep.
to do it ever again. And so we definitely and I salute you guys for doing this and really to pushing the envelope, because we really have to be forward thinking and transform the way that we educate our residents and also becoming more efficient.
Mhm.
Unfortunately, residents,
Absolutely.
in my opinion, are underpaid.
Mhm.
But by the time some residents are done with their training, they're, starting their job. And
Yeah.
so, but with all of this being said, what do you find the most challenging about competency-based training? Do you think is it faculty engagement, evaluation consistency, accreditation, and what do you think is the most challenging, and sort of how have you navigated that for the programs that may be interested in joining this initiative in the future?
Yeah, that's a question that's like, the first answer is like, how much time do you have? There are
Yeah.
so many issues associated with it, right? Time, money, effort, logistical support, faculty development. All of that, I think, is wrapped up in the notion of culture change. This is a paradigm shift in regards to education, right? This is like equivalent to the Flexner report and really formulating the current model of time-based training. So this is really a sea change, and we're not changing everything, right? We're not throwing the baby out with the bathwater. We're taking an existing functional structure, and what we need to do is take, for example, the valid subjective summative evaluations we do every rotation, every semester, and then adding to that objective formative assessments that provide real-time feedback that's actionable for both our purposes of assessing people and the trainees' purposes of getting really granular, frequent, formative, actionable feedback that they can really work on. But that process is a complete sea change from what we do now. And so it's change management, which is something that, I don't have an MBA yet, so I don't know all the ins and outs about that.
Yeah.
But well, yeah, so we were fortunate to get an endowed chair, so we got to spend some of that. I think
Yeah.
we're thinking about maybe a dual degree, getting a master's of education and getting an MBA, so we can just really extend all those letters after our name.
You should.
But
That'd be awesome.
that's the formal education component, right? You know, we were once like professional students, and then we became residents and physicians, but those are old muscles that are a lot of fun to flex when you do kind of that
So
formal
much fun.
education. Yeah.
I'm actually in the midst of getting my MPH right now, and I had somebody
Yeah.
text me the other night about how does it feel getting my MBA, and I said I'm not getting my MBA, but I can't wait to. It's like,
Yeah.
especially when you're at a place like Pittsburgh Penn, taking advantage of your surroundings makes total sense. But going back one step, you know what I think would be incredibly valuable, because I can tell you the talk at Penn is about the competency-based training is the logistical nightmare
Mhm.
aspect of it, for
Yeah.
sure. And I do think that a lot of programs are probably fearful of that. I think one thing that would be incredibly valuable if at some platform, I know you're planning to do some of it at ACAPS where, and I want you to talk in a second about what your plan is at ACAPS regarding like the competency discussion. I think you and Josh are doing some sort of a debate. Is that right?
Well, that's a debate about competency in a way. That's a debate about, programs, about integrated, independent, dual track programs.
Yes,
That's a
that's right.
whole other big problem in plastic surgery, right? Managing the supply and demand issue that we have.
Yeah, so I think one thing that would be very valuable is that if you could just, at some way educate so many other program directors to say, okay, let's assume you're in a competency-based training program. This resident graduates early.
Mhm.
This is how Pittsburgh navigates that issue. We pull this person, the call pool then gets covered by this person because we have a few people out right now. Fortunately for our program, I think we've become, you know, very much, a family-centered oriented program. And I think we have
Mhm.
maybe up to 5 to 7 individuals who are gonna be on either maternity or paternity leave this year.
Yeah. Yep.
And
As
when
it
these
as it should be.
as it should be, which is fantastic, but we've developed this way of making it work when they're gone, and I think we all
Mhm.
realize that you can f and so I think it'd be incredible valuable for people to hear from you at in some national platform, how do you guys do it?
Yeah. I mean, you definitely it's definitely easier for larger programs that have resources, capacity, X number of residents, right? It's going to be a lot harder for programs that are smaller, have 1 to 2 residents per year. Resident is out, resident graduates early. That's a big deal, right? But for us, I think the additional thing is you have to build in intrinsic flexibility to the system. And so one of those things we did way back when, even before the competency system, is downshifted our rotations to where, again, we're kind of accelerating the education on the lower end and having that sixth year really be an elective year, having a ton of elective options in it
That's great.
and potentially having the whole thing be elective because somebody may graduate early. So we can't really depend upon having a
Yes,
full cohort that last year.
that's
And
great.
then you have to build flexibility, and the other rotations kind of have system level coverage where some residents are kind of floating and they're going to wherever the needs are because there's always needs. Either, you hire more faculty or a resident is out on maternity leave or somebody is sick or somebody's parent dies or whatever happens because life continues to happen, particularly for these guys that are in the critical years of their professional and personal development. You got to build flexibility into that system.
Yeah. So I'm gonna put my APD hat on and say, this year of elective time, do you find I'm fully so I was a reason why we got elective time in a very old school residency program like Hopkins, but do you find that a year worth of elective time that residents are disappearing for the year, or do you find them truly using that time and doing things?
The honest truth is it depends upon the resident, right? So just to be clear, if anyone in the American Board of Plastic Surgery is listening to this, it's not a year of elective
Yeah,
time
yeah.
because it's limited by the board to 12 weeks.
But I'm saying, like, let's perhaps the future is a year or something, you
It could
know?
be.
I'm just saying whatever that time is, yeah, I guess it's dependent on the situation.
So the philosophical notion is that you trained residents that have an individualized educational track that they are now active learners within the system, right? There's not nothing wrong with a resident who shows up and says, I'm going to be here for 6 years. I'm going to go through the paces. I'm going to perform well. And likely they're going to be competent at the end. But if you build into that educational paradigm the notion of that the learner is the active center of that educational system, they are ideally going to take advantage of all those things that are in the pipeline, right? They're going to do the extra lab year. They're going to use that lab year to be able to prospectively plan for are they finishing in 5 years or 6 years, and therefore they have to apply for a fellowship in 4 or 5 years. And if they do stay for 6 years because they want to and they find it to be educationally beneficial, they're going to maximize that time. They're the person that's going to go to Chang'an to do micro or go to Ghent to do gender affirmation surgery, go to California to learn rhinoplasty from the experts. They're the people that are not going to sit on their hands because they recognize the value of that time because it's limited. Because once you're out, you're independent. You're always connected. You can always, phone a friend and get advice, et cetera, et cetera. But, you're in that operating room making choices at some point.
Yeah. This takes me kind of to the discussion a little bit. Some of what you just said, it makes me think of like, what are predictors of people who are perhaps going to pursue academic excellence or academia? And, when I think of Francesco as a resident, he is somebody who, like, seeing as a resident, I knew he would pursue academics. Do you have in your mind, like, I don't think I have a strong grasp on seeing a resident and knowing if they are going to pursue it. In fact, I almost feel, and I had this discussion on a different podcast with Kyle Eberlin, I almost have this thought that we're almost pressuring medical students too hard to do research, that a lot of them aren't
Yeah.
falling in love with it. It's just a numbers game. And then it's almost driving them away.
Yeah, they're
And
kind
so
of burned out on research.
yeah, so I'm fearful that, like, I don't know what a good predictor is of somebody who potentially will join the academic workforce and have a passion for education like you.
You know, I think whether that's the goal is training academic superstars, surgeon scientists, entrepreneurs these days, all the things you're doing, or it's being a leader in your community. You go to wherever and you start really taking great care of patients. You're on hospital committees, you're in the community doing different leadership style things. It doesn't have to be on the society level, the national level, but kind of leading within your community. I think that's evidenced by people that come to your program and they really take advantage of the opportunities that are there. There are so many opportunities in any program, but you can't be passive about that, right? People are given opportunities and then you have to walk through that door. You have to imbue that situation with your energy, your momentum, your willingness, your passion to pursue that. And that could end up being your passion. It could end up not ultimately being what you want to do, but it informs you in regards to, is this really something I want to do in the future? So I think the telltale sign for us are residents who really take advantage of all the opportunities that come their way. And a lot of it is a yes game early on and just kind of shotgunning and saying yes to everything. But at some point, whether a senior resident or certainly as a faculty member, you start saying, okay, I need to have some autonomy in this. I need to figure out what's meaningful for me. That can change as your life changes. You go from a single person and you get married
Yeah.
or you have kids or whatever, milieu is out there. But then you've got to figure out what your North Stars are. And that can always change and you need to constantly reassess that. But that really helps you make decisions that are right for you and really helps you tolerate the consequences and live with those consequences and the trade-offs of those decisions.
Yeah. So I'm going to ask you kind of an important question, and that's the purpose of sort of this podcast. And so a lot of when I'm talking to residents, a lot of the deciding factor is money. And if you ask me on day one, when I was looking for a job, do I care what I would be paid? I would say absolutely not. And that's what I was saying when I was being interviewed. I actually don't even think I ever negotiated for my salary, ever. And perspective changes. You have 4 kids later, you buy a house, things like that happen. But when talking to residents, a lot of the residents that voice their interest in private practice, aesthetics, whatever it may be, the driving force is money. And, maybe not all of them, but definitely some. And that, it's the debt that they've come up with and they don't want to go to academia and
That's very real, right? That
yeah.
that debt is tremendous, and the compound interest of that is can be bury people.
So what do you tell those people about like the differential pay between academia and private practice?
Yeah, so ideally we show them the data, and hopefully that matters. If you look at the data, the mean income, whether you're academic or private, is almost the same, maybe a little bit higher for private practice. But again, private practice is tied to the economy. So you could have banner years, you could have bust years, but overall, you're going to do well. And I think if you look at the happiness data and you look at that related to income, it is true that a certain income is tied to fulfillment and happiness, but it peaks. There's a level that beyond that, your happiness is not going to increase. It may actually decrease.
Mhm.
That phenomenon of the lottery winner who gets all this cash and their life just completely tanks. It happens over and over again.
Yeah.
And so again, ultimately it's not about the money. I'd like to say it's about fulfillment and happiness and what's going to achieve that, particularly for the long run. So money can do that to a certain extent, but I'd like to think that most plastic surgeons, regardless of what you do, are going to hit that threshold where again, more money is not make that much of a difference. Once you've been able to take care of your family, take care of your loans, have a stable income, and most of us have more than we really need. And again, I think that's when people struggle with issues of, you know, I have all this stuff, I have a Ferrari, and I don't think I'm intrinsically happy. It's because that you've gone past that threshold and those additional things can bring you a little bit of temporary pleasure, but not sustained happiness and fulfillment.
Totally. Yeah, no,
Yeah.
and that's what, and I wanna get that out there. I want people to hear that, and I think, like, take me, for instance. I think there's a lot of priceless things, that invaluable things that I think of on a daily basis about what I love about my job. Today, I did 2 cases I've never done before, and I did it with
Nice.
residents, and I got to take them through it, and I absolutely loved it. But I love everything you just said, and I think it's important for people to hear. I do think that there's temporary rewards. You have to sort of look beyond that, and I encourage anyone who's listening today to also talk to your mentors too when you're having this struggle between future career paths, because ultimately you want to be happy with whatever you do. And you also touched on kind of this, we talked for a second about committees, and you're co-chair of the GME well subcommittee on
Yeah.
well-being, is that right? And
Yep.
that's kind of a mouthful. Did I say that right?
Yeah. Yeah.
Yeah.
I think people get the gist of it.
But, and we just talked about, maternity, paternity leave, which is really fantastic for our program. But how do you
Mhm.
think building a training culture that supports all of this resilience, psychological safety, professional growth in a demanding surgical environment, those almost seem like
Absolutely.
opposing forces.
They are, right? They're exactly opposing forces. And so my co-chair on our task force, which again, we're tasked to cover well-being for the entire PIT GME, which is over 200 programs, about 2,700 trainees, and 50 different clinical sites. So it's a relatively big group and a really diverse group. So that dichotomy is inherent in everything, and it's a binary situation. It's what's considered the dialectic. How do I thrive as a resident, clinician, faculty member within this, you know, this heavy healthcare system, this sometimes, if not completely broken healthcare system? So you have to embrace that dialectic or that polarity because it's not changing anytime soon. There are system level changes, and the well-being movement has been going on now for decades. But I think we're at kind of a turning point. There's this notion of well-being 1.0 or resilience 1.0, where, you know, you're asking people to have this minute of mindfulness for you walk in a patient's room or to do more hot yoga. But what you're really telling people to do is that you're on the precipice of burnout and you need to do more. You need
Yeah.
to be better. You
Yeah.
need to, you need to suck it up and just, lift more. That probably is not going to work out. And I think the notion is really, while there are system level changes to really address those system inequities, which is going to take time and is a really heavy lift. On the individual side, you need to, again, find autonomy where you can, find your meaning within this, find your North Stars to be able to make decisions. Give yourself some grace and say, I've done enough, whether it's on a daily basis or, within a rotation, you've probably done too much. And then give yourself the space also for recovery, because there's this notion of resiliency 2.0 or well-being 2.0 now, because resiliency has kind of gotten to be a dirty word, right? You need to be more resilient. That doesn't really fly anymore. So the notion is that you have to both accept the stress, because surgical residency is a heavy lift and it is stressful. And then you have to recover from that stress. You have to build in some element of recovery, whether that's physical activity, spending time with family and friends and your kids, having a spiritual outlet, or just building meaningfulness in your life. There's all these kind of paradigms that you can do to try to be, well and resilient and thrive within a system that is not intrinsically built to support that.
Yeah. So I'm going to say the obvious. How can you do all of that stuff when you can't do it? Like, if you're a resident working really, really long hours, how do you find time? And I do worry about this. Like, you're right. Like, sometimes I feel like when you're down and you're trying to cope, more gets added to your plate, almost in a counterproductive sense. But Everything you just said makes perfect sense. Find time, find meeting, find time, spend time with family, all this stuff. Like, what are the actual steps that people, like, if someone is struggling, like, what do they do? How do they find that time? Like, you can't just take time away from residency.
Yeah. I mean, what's the real world situation? The real world situation is tough, right? That's part of the systems level change, whether you believe it's reduction in duty hours or building in wellness days. There are system level
You
ways to
guys do
be
that well.
mindful somewhat. The other thing are unions and while many of us don't look forward to dealing with a union, in certain places that might be the right solution in order to be able to create some autonomy for the residents to
Yeah,
make some of those decisions.
you're right.
But those little systems level changes can create a little bit of space again for residents to be able to have that recovery. But we're in a tight spot here, right? We are dealing with an old paradigm and trying to switch again to another new paradigm. And so you come up against a lot of a lot of issues. And like you said, no one can create more time. You have only so much time and energy, and it can be somewhat finite. And we're not, fixing all the problems for trainees is a big, big thing. Can we do can we do little things to do that, both from a system level and also from an individual level within a residency, within a particular, residency group for a particular resident that needs a certain thing? Again, you have to build in some flex into the system to allow people to get what they need. And
Yes.
there's a ton of resources out there that can, whether it's childcare resources or mental health resources, coaching, for example. Some of that involves also kind of, a change in mindset, which is easier said than done in regards to kind of, finding those meaningful points or reconnecting to what it means to be a surgeon, a physician, a clinician, a resident, a learner. None of it's easy. But again, I think we've got to figure out, a lot of the meaningful things in life aren't super easy. And it does get better because from a time point of view, the flip side of not having time is that no one stops that clock. That clock keeps on ticking. And so you find those moments of recovery within a day, within a week, within a month, within a year, within a lab year to get time off, within the end of your training to be, I think most of our residents as they get further up in seniority have a little bit more autonomy, a little bit more time, a little bit more flexibility. Certainly have it as a fellow. And then as a faculty member, you could get again kind of overburdened with all these things that you feel like you have to do, you need to do, people are asking you to do. And in general, you should probably say yes to a lot of opportunities, but at some point you make some decisions, right? You kind of start following your North Star or stars and saying, this is important to me. This, as painful it is, I'm going to have to let go just because I can't do it.
Yeah, like what we were talking about earlier, education and research and things like that. And I think your topic of recovery is so important because I know for myself when I take that time, the word recovery is so perfect for it because when I come back, you feel refreshed and it's so important and you need it. To anyone who's listening, resident medical student, faculty member, every single person needs that. Every single person needs it, and you have to take it. And then the only thing I'll also add to all of this is like teamwork. When you're struggling and you're down, relying on your colleagues or relying on your mentor to be able to talk to them and things like that, and to find time for a break, whether that's changing a call shift or whatever, changing your
Hmm.
grand rounds presentation. I think all of that's important.
Yeah, absolutely. I think just as you're alluding to, no one does this on their own, and we are in teams for a reason. And all you need to do is ask for a little bit of help, and people will come out of the woodwork to help you. That's been my experience. I mean, we work with really good teams. We're in a helping profession. Sometimes I think we forget that, and that there are helpers all around us. We just kind of need to just reach out just a little bit.
Yeah. The two other topics I want to touch on are the independent versus the integrated resident.
Mm,
It seems to be kind of a popular national topic, but
yeah.
what do you think the future holds with regards to the independent track? I remember when I applied as a general surgery resident, I think it was 2015 or something along those lines. I remember the topic of discussion was in 5 years,
It's
they're
going
not going to
away.
be, it's going to go away. And now
Yep.
we're 10 years later, and there's still a lot of programs. So what do you think? Do you think that we're going to keep it? Are we going to kind of transform it? It's going to be something else in a few years, but it's going to still be an option. What do you think?
If I have anything to say about it, I think we need to not only keep it, but we need to expand it.
Hmm.
So we have again that problem of way too much demand for the supply we have, which is a great problem to have, but is a real problem, right? The integrated match has gotten to be so ultra competitive. It's crazy. And
Crazy.
so we can't necessarily keep this up because these kids are gonna burn out, or people are gonna look at that and say, I don't think I can do that, and we're gonna lose a cohort of the best and the brightest. So there are constant pressures to get rid of the independent program. There are divisions turning into departments, and they have more funding, more staff, more educational value. So they want to develop integrated programs, right? My argument is that you need to be mindful of those numbers and ideally keep the independent positions, because in the short term, we're asking all these people who aren't lucky enough to match into the integrated system to funnel into the independent system. We have to also convince general surgery that these people are some of the brightest and best residents you'll ever have, and to reduce that bias they have towards those residents that are dual applying to plastic surgery and general surgery. And then it's up to us to keep those independent positions alive. If you're a division going to a department, keep your independent track and add integrated positions. If you're an integrated department that has independent positions, continue to grow both. And if you're an integrated program and only an integrated program, you need to think about adding some independent positions. They're easier to fund. You have already the educational value. You've got this growing cohort that are going to be funneled down the independent track. And we need more positions. We need more plastic surgeons. So we need to train more people. And in the short term, by bolstering the independent track, and really, I love having both tracks. And the last time Pitt expanded its residency, we added an independent position, not an integrated position, because we believe in really that cross pollination of the two. Our integrated people help the independent people get up to speed, right? They do a Whipple the last day of their general surgery residency on their own. The first day of plastic surgery, they've got like a nail bed laceration, and they're like, what is this? And so our integrated people really get our independent people up to speed. And our independent people are kind of like, junior faculty. They really help our integrated people, accelerate in regards to particularly the non-clinical competencies, communication, how to work in teams, how to run a team, how to take care of a critically ill patient. And so there's so much cross-pollination that happens between the two. So we're really committed to keeping both and expanding both.
Yeah. It's funny. You talk about Whipples. I remember doing a Whipple, I think the week before I came to Penn. And then I come to Penn and I'm doing breast recon with Lisa Wu. And she's cutting out my deep dermal stitches. So I go from
Yeah,
being a chief resident running the service, complete autonomy, to getting my deep dermal stitches cut out as an independent four. So
yeah, that's a tough transition.
it's a tough transition, but the other night I was at Journal Club and the chief resident who was presenting an article was one of the independent residents. He was going into an academic job at Wake Forest. And I
Wow,
was
great.
so proud to hear him talk about plastic surgery and to think about how much he has learned in the 3 years. And when I see our graduates at 3 years, the integrateds are just like the independents, like they make it. Like you can become a well-trained plastic surgeon through the independent track. Absolutely. I have
Absolutely.
no doubt. And
Yeah,
it's really nice to see.
yeah, I would agree completely.
And one of the other things that I was thinking about is specifically with the independent track is back in the day, there was the whole combined 3+3. Now there's the integrated. And then the independent track was 2 years and now it's 3 years. Do you find the 3 years to be the right balance?
Yeah, I think so. I think it's, plastic surgery, all of medical, knowledge, scientific literature continues to expand, and plastic surgery is again with our, basis of innovation constantly expanding, right? So I don't think we can make it any shorter. Could it be longer in the future? Yeah, but it's a lot to cram into 3 years.
Yeah. And then, this is, like I said, probably going to come out around the peak of the interview season. And so probably towards the end after interviews. And so I have two questions that I want you to kind of help the audience with. Number one,
Mhm.
interview's over. You're an applicant. What's the next step? Do you just wait? Do you reach out to programs? Do you have your mentors reach out to programs? Like, what do you advise? That's
Yeah.
question number one. Question number two, match day pops up. You don't match. What's the next step?
So, in regards to finishing your interviews, I think that you can have your mentors and people that are connected reach out. Does that really make a difference? Probably not. But again, the system is so competitive that anything little thing you can do could help, likely won't. You know, and even those people that don't have, hopefully everybody going through plastic surgery has mentorship and guidance. You may not have a home program, but you have a surrogate program you can reach out to. Don't be afraid to reach out to people that you know and say, "Hey, I really like this place. Do you know someone there? Can you advocate for me?" Send something out. You also have to kind of strike that balance, right? You probably don't want to send out 60 emails that are kind of, formulaic emails to every attending that you know. And then it just, you have to, you know, play the game, so to speak. In regards to not matching, that situation is I think more prevalent than ever. And the literature on that reflects that you need to, you know, do a debrief yourself and the people that you trust and you're with about why you didn't match. And if there's a reason why you didn't match, your next step should be tailored to that. Is it because you went straight through and you don't have enough research to be competitive? I mean, you hate to say that, but that's the honest, that's the honest situation right now. Yeah, you have to you have to have a competitive CV that puts you in the mix with everybody else so that people can get to meet you and know you as a person and figure out that whole match. So that's one thing. Then that person is ideally going to, you know, go through the SOAP, but again, virtually no open plastic surgery positions and even general surgery positions. Last year there were 2 categorical positions open in general surgery, and the other handful were all prelim positions. But if you can SOAP into a general surgery categorical position or SOAP into a prelim position, you're on the track, right? If you get a categorical position in surgery, plastic surgery, general surgery, I don't even know about the other surgical specialties, but a categorical position, that means you're now on the independent track.
Mhm.
So you just stay the course, you be the best resident you can be, you publish, you're active, et cetera, and then you apply for the independent match, which is getting to be more competitive, but is certainly less competitive than the integrated. And many people can go through that route. But if you're not successful in the SOAP, then if you need research numbers, you get a lab position. And that's oftentimes for 2 years because a 1-year position doesn't really get you enough on your CV for the next application cycle that's going to start in October, right? And so that's usually a 2-year lab position. If it's something else, if it's the dreaded low step score, that's very tough because again, step 1 and now step 2 is likely the biggest screen for applications. So it reduces the 500 applications that went through this year to something that is digestible for a residency to do. And I don't think there are many programs like maybe us or you guys at Penn that can look at every application that come their way because we have 20 plus faculty members to look at that. Most programs have 6, or it's just the program director looking at all those applications. So they logistically have to reduce those. And the biggest filter is a step 2 score, I think. It was a step 1 score in the past, and that was proven in the literature. And we'll certainly see literature that likely proves the case for step 2. That's a tricky situation because that step 2 score will kind of always be there. So the prevention for that is really to focus on your step 2 score and really to take that as prepared and oftentimes as early as you can. Because if your step 2 score becomes non-competitive, you may think about changing your course during your 3rd and 4th year to really focus on the general surgery match and getting a categorical general surgery position, which still puts you on the track for an independent plastic surgery position. So that takes some pre-foresight and some pre-planning if you're able to do that and if you have mentors and guides that can really help you with that. But again, it's kind of like, what's the diagnosis and what's the solution for that to be able to really effectively reapply or make a general surgery categorical match a possibility.
Yeah. And I
Yeah,
definitely
tough.
don't, I think back to, I remember very vividly sitting in medical school audience, and one of the ENT faculty member goes up, and the medical students are asking him, "What does it take to get into ENT?" And he's like, "You have to be AOA, top of your class, this, that, and the other." And a lot of our conversation tonight is about the extreme competitiveness of plastic surgery, but I definitely want to not discourage people, because I feel like we're putting so much stress on applicants these days that I just want to remind anyone who's listening that if you want to be a plastic surgeon and you work hard, you will become a plastic surgeon. There's, just like Dr. Nguyen
Absolutely.
just said, there's the independent track, but I think the one thing that it takes is hard work and discipline, and you will absolutely become a plastic surgeon. So don't be discouraged by any means by anything that we've talked about, or that anything that anybody tells you. But sort of along
Absolutely.
those same lines, I wanted to ask you, before I ask you the two last concluding questions, I think to myself, what would I do differently as a resident, perhaps in life? I know for me as a resident, I think particularly as a junior, I was so focused on reading, studying, research. I didn't get into the OR as much as I would have liked to do in my first kind of junior years, where I'm developing it rapidly. For you, what's sort of one lesson you wish every resident understood early in their training?
I like the notion, and I think it carries through maybe lifelong, of being comfortable with being uncomfortable. That
Yeah.
your learning zone, what's called the learning zone or the zone of proximal development, is where you're uncomfortable, right? Getting beyond what you know and what you know you can do into that uncomfortable zone, that's kind of where the magic happens, where you're really learning, which also means you're making mistakes and errors, right? But as long as that's in a system that, again, can catch those errors before they become actually patient related issues, that, and as long as you're learning from those mistakes, you say, you know, I made a mistake, I accept it. This is what I did wrong. This is what I'm going to learn from it. Do next time. That you accept those errors and you get into that uncomfortable space where you're really learning. That, I think, requires you to kind of push yourself a little bit out of that comfort zone that we all have.
Yeah. Any regrets that you have in over your career, or yourself, that you think others could learn from?
You know, I try not to regret things because, again, even the mistakes or the errors that have happened have gotten you to where you are. And I think if you can be happy and satisfied where you are, then that's all part of your history. I would say one piece of advice that I would give people is that in this day and age, when you're looking for job number one or job number two, that you think about what's important for you and you negotiate those elements into your contract. My first job was in 2007. And at that point, I think it was still the old paradigm. You're expected to be 100% clinical and research, education, administration, society work,
Where were you?
advocacy here at Pitt. It's my one and only job. Yeah, you're expected to do everything else, nights and weekends and, et cetera, et cetera. And I think I tried to do that for a while, and I figured out it didn't work for me. So I had to subsequently carve out time, support, salary support for education, for research, for other things. And there are some people out there, I think, who can, who are, I think, like you, like Francesco Egro, who can seemingly do everything and make it look easy. But for the rest of us, you gotta get up a little extra early and spend that half an hour to an hour just focused on things while your spouse and your kids are asleep. Or you carve out time to be focused on this so you can go home and be focused on you or your family or your spouse. So I think it's about, again, I think a theme of what we talked about, you know, figuring out the autonomy where you can, making decisions that are the right decisions for you, and you live with the consequences. But yeah, negotiate from the beginning, time, support, money, et cetera, et cetera. So you don't have to carve it out on the back end, which gets to be really painful as you try to, kind of do less clinical and carve out more other time. be smart from the beginning, and those things that are really important to you, make sure that those elements are in your contract.
Yeah. That's one of the problems with this podcast. I feel like every question I ask, I think of another question and then it can go on and on and on. But,
Yeah, absolutely.
and of course, like I do want to ask one other thing. So, and this is probably something I don't know if you've ever struggled with it. Clearly, you don't know if you ever envisioned yourself being in Pittsburgh forever. But I'm now into year 4 of being a faculty member, and sometimes, one of the things I struggle with is, am I at the best
Mhm,
place for me?
mhm,
Is it time to move on? Is it time
mhm.
to, take my family to a different location, see what other opportunities there are out there? And, that's the purpose of a podcast is to be honest, and I
Mhm.
can't say that that doesn't go through my mind.
Absolutely.
So, how do you deal with those thoughts? And, it was funny, I was talking to my sister earlier on the phone, and she tells me because she's had 5 or 6 different jobs, she told me, you think that things are different elsewhere, then you go to this other location and it's exactly the same,
Mhm.
or so how do you deal with, like, this
Or it's different.
or it's different? How do you deal with the struggle that I'm kind of having is that, I love my colleagues, I love where I am, and, but by us, we're lifelong learners, we're adventurers, we love the surprises, we love the risks, and we love trying different things, and but you have
Yeah.
stayed put for so long.
Yeah. Yeah, we have, and I think, we have a lot of faculty that have been here a
Yeah,
long time, and
same like
I
Pat.
think yeah, exactly, and I think that speaks to the department, the division, the program, the culture. But that struggle that you have, that's where you wanna be, right? That means that you both care about where you are, but you also, like you said, wanna find the best environment for you. And so you should look, right? Because honestly looking, and not just, going because you're kinda going through the paces, but taking an honest look about at a place tells you about that place and tells you about you. Because you, again, say, "Okay, what's important for me? This place is different from that. The culture is different. I mean, what speaks to you in that situation?" And you really learn so much about yourself when you're struggling with those things. And then you figure out, "Hey, am I changing? Do I wanna go to this new place because it has this new thing and it has a different culture?" Sometimes you find that things are oftentimes different. Things are not always better, and sometimes things can certainly be worse. There are, things under the surface that you only find out by really looking. But looking also informs you about yourself, and it gives you, in academia, the negotiation and the leverage to be able to improve your situation and change your home situation into a better situation. So you can change even staying in the same place because your situation changes. And in academia, the most common change occurs when you're being asked to look elsewhere.
Yeah,
So I would encourage people to do that because that's the academic situation. That's the chessboard where people move around.
no, you're
I
right.
think some people I have been, I've been given advice by people that said, "I moved, and boy, was that a mistake because I didn't have the community I had in the past. I didn't have the support I had in the past. I'm still struggling to kind of rebuild some of those good aspects I had in the past." So you have to really make some tough decisions, but that's how you learn and grow.
Yeah, I think one of the things I'm so blessed by is my surroundings and the people that I work with, and I think that's one of the things that if you have to be sure that you're in a good team, I think that that's an
Yeah.
important thing.
And sometimes you only learn that by looking elsewhere and you recognize what
You
you have.
recognize it. Absolutely.
Yeah.
All right, a couple fun questions. If you weren't an academics, educator, plastic surgeon, Pittsburgh, what would be your other job?
At the risk of sounding too similar, I think, at least for me, I think I'd be a chef. I
Okay.
love to eat,
I was
maybe a
gonna
little
say
bit
that.
too much. Yeah, and so I love to cook, and I think that whole, kitchen, the whole French brigade, whatever the whole kitchen situation has so many shades of the OR, right? There's
Yeah, yeah.
culture there, there's positions and responsibilities, there's personalities. I think I would find that a lot of fun. I think, every now and then Joe Losi and I kick around the idea of our next thing is maybe we do a restaurant
Yes.
together or like a Dean and
That'd be
DeLuca where you
awesome.
can really get,
I
you
would
know,
love that.
neat stuff from.
Yeah.
There's a little spot near us called on Walnut Street where there's a place that closed down, and we thought maybe we could develop something there, but we'd have to step away a little bit from our day jobs. I think we
That'd
both
be
like our
super
day
cool.
jobs too much right now. Yeah.
I love that. I love that idea. There's a chair of surgery at Brigham, Zinner, an old Hopkins guy, but he had a restaurant and it was a passion of his. But it was interestingly, like, I don't think I could see myself as a chef, but I would love the restaurant business.
Yeah.
What's your
You can do
favorite thing
front
to
of
cook?
house, we'll do back of house.
Yeah, exactly.
Favorite thing to cook. I try to cook a lot of different things. I would say one thing that I think that I've just come across recently is this miracle combination of butter and miso. You can put it on like anything. Bread, noodles, chicken, steak. It'll like improve just about anything.
Wow.
One recipe that comes to mind that I like to make on a semi regular basis for special occasions is lobster pasta. You know, taking that live lobster and dispatching it, which is the closest I think we ever get as normal citizens to farm to table, where you really kind of are, at least for a little while, related to your protein. You got to dispatch that lobster. It really teaches you the value of what you're cooking, because this was alive at one point and now it's not. And then partially because that recipe comes from a restaurant in Montreal called, it's not a pied de cochon. It's one of those big French Canadian restaurants that tries to kill you with food. And if you look at the recipe online, there's one point that says, I think it's about dispatching the lobster. So it's a really kind of tongue-in-cheek recipe that we really love because it's really kind of off the beaten path and fun to cook also.
Yeah. I'm in. I'm going to invest in you and Joe Losi's whatever it is. $50. I'm in.
Yeah.
Right away.
Got to start somewhere.
All right. Favorite OR music and favorite surgical instrument?
Favorite OR music, I used to be, or maybe I'm still a club kid at heart. So I love all kinds of music, maybe country and Western a little bit less. But if you're in my OR, you're likely listening to EDM, some type of
EDM.
electronic music.
Love it.
Usually kind of house, trance music, something that kind of keeps the rhythm, helps out in those long free flap cases, and certainly helps out during closing. You kind of turn it up a little bit and everybody's kind of, whip stitch and stuff. Yeah.
It's funny because I think to myself when it comes to music, the old school way of it was like no music in the OR. And sometimes I think to myself, like, when I need momentum or I need help in the OR, I need a certain kind of music.
But yeah, I got to have music in my
It's
OR.
almost like times have changed a little bit,
Yeah, I think so.
Anyways, all right, it's favorite surgical instrument.
Okay, I would say favorite surgical instrument used to be the Freer periosteal elevator.
Sir, let me disciple.
Oh, yeah. Not for, again, bony dissection, but soft tissue dissection.
He loves
microvascular dissection.
Yeah.
It can get you out of some pretty literally sticky situations. I would say, because my mix now is heavily implant-based versus free flap. We don't use it all that often anymore. So really, what I jokingly say is my favorite OR instrument is the ring clamp, because it's in every instrument tray. Nobody uses it. So I can always know it's there when I want to change the volume on the music and turn it up a little bit. So that's literally what I say is my favorite instrument now.
That's awesome. Well, thank you so much. Like, this went way over. I'm sorry, but this is what happens.
No, that's what happens when you're having fun.
No, it's a ton of fun. I think I'm so excited for listeners to hear from it, especially I feel like this time of year, but you add so many unique perspectives with regards to competency, well-being, life fulfillment, and all the rest. So I learned a ton. So I owe you. That's why $50. You have $50 for your.
Sounds good. Thank you, Said, so much. This is so enjoyable, and I think hopefully we'll be educational, or at least provide some good entertainment for folks.
Awesome. Thank you.
Thank you for listening to The Deep End, a plastic surgery podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at The Deep End Podcast. Join us again soon for more conversations with luminaries and experts from the world of surgery.